But welcome everyone to IPHA's third Thursday Lunch and Learn series organized by our Education Committee. We like to dedicate this time every month to sharing our successes and even some of the detours it takes to get to those successes, because those can help us grow too. The point is to connect, learn, and strengthen the voice for public health in Iowa, which of course is part of the mission of IPHA. If you're a member of IPHA, we thank you for that. And if you're not yet a member, we invite you to join us and to help carry out our mission. You can do that on our website at iowapha.org. Today, we're joined by Roxanne Cogil, who will share about epilepsy and seizures. But before we get into it, a couple housekeeping items. Your microphone is muted and your camera should be off during the presentation. This helps us save some bandwidth and make sure everyone can see and hear during the presentation. You can put your questions in the chat or Q&A features here on Zoom. And then towards the end, we'll open it up. You can turn your cameras on, turn your mics on if you'd like, and we'll have some Q&A. The session is being recorded and it will be posted to the IPHA YouTube channel once the event is over. But now I'll turn it over to Roxanne so she can introduce herself and teach us about epilepsy. Roxanne?
Thank you, Brett, Lena, Kim, and to the Iowa Public Health Association for the opportunity to educate today. My name is Roxanne Cogil, and I'm the Executive Director of the Epilepsy Foundation of Iowa. And I've been serving in this role for nearly 10 years across the state. And what our organization does is we provide support and services to individuals, families impacted by epilepsy throughout all 99 counties in the state of Iowa, as well as providing resources and information to professionals who serve people with epilepsy and seizures. I'm sure that in your role in public health, you've encountered individuals, family members with seizures. And one of the biggest things that we do is we provide education. We receive support from the Center for Disease Control to develop standardized curriculum to deliver across the country to a variety of groups. And so we have specific education programs for school staff, school nurses, and students, which are part of our Seizure Safe Schools initiative, as well as a new seizure first aid and certification program, which was launched in 2020, where you can become certified in seizure first aid, which is a 2-year certification. And then we have other education programs on psychogenic seizures, rescue medications, employment in epilepsy, and all of those programs are available on our learning management system of learn.epilepsy.com. Anybody can go to that website, create an account, and go through the modules and take courses at no cost. So today's program is on Epilepsy and Seizures 101. We did submit an abstract to present at the Iowa Public Health Association Spring Conference. So we're waiting to see after the first of the year, I believe, if we get approved for that or not. But we did submit it for our Seizure First Aid Certification Program. So this program today is we're going to cover the basics. I want to make sure that everybody leaves today knowing more on the differences of the types of seizures and basic seizure first aid. And so we're going to cover epilepsy and seizures, the initial workup of a person that potentially may have seizures or epilepsy, and why epilepsy is considered a spectrum disorder. And then we're going to wrap it up on seizure, a little bit of seizure recognition and first aid. So epilepsy is identified by the Center for Disease Control as a chronic medical disease. And it's one of these conditions that many people are very fearful, and it's not talked about a lot. And people are so surprised when they see the statistics on how common it really is. There's actually 65 million people across the world that live with this condition. When you look at across the United States of America, it's over 3.5 million, over 470,000 children and youth, and over 1 million older adults. It's a lot more common than what people realize. But for an epilepsy diagnosis, 1 in every 26 people will get an epilepsy diagnosis by the time they reach their elderly years. That's about 1 student in every classroom. And our daughter was actually diagnosed with epilepsy at the age of 2. My husband and I didn't know anybody with epilepsy diagnosis growing up or amongst our friends or colleagues until our daughter started having seizures in public. Then one by one, people we knew from over the years came up to us privately and shared about their seizures after their motorcycle accident or seizures after suffering a severe concussion. And they just never talked about it. And so, and here, come to find out, we knew a lot more people than what we had thought. But effective management with epilepsy begins with observing, recognizing, documenting, communicating. And it can be very challenged because a lot of different types of disabilities or medical conditions are constant. But with epilepsy, it's very unpredictable. The signs and symptoms can be subtle and difficult to recognize. Over half of all seizures do not even involve convulsions. And some of the symptoms look like other health conditions or comorbidities that that individual may have. So when we look at a seizure is defined by a disturbance in the brain. And so abnormal electrical discharges in the brain cells is what occurs. And some seizures are provoked and other seizures are unprovoked. So provoked seizures, an example of that would be, for example, somebody that has, let's say they have diabetes and they have major changes in their blood sugar. That could provoke a diabetic seizure. So that's not epilepsy, that is a provoked seizure. Another example is in a child that has a febrile seizure where that seizure is provoked by a high fever. Now, unprovoked seizures is what the physicians are looking for in an epilepsy diagnosis. So epilepsy is a brain disease. And so what physicians look at, or how this is medically defined, is 2 or more unprovoked seizures at least 24 hours apart. Or the International League Against Epilepsy looks at it as 1 unprovoked seizure with the risk for recurrent seizures. So there could be data on imaging or on a video EEG that shows that abnormal epileptical brainwave reading of likely seizure activity. Or that individual has a diagnosis of an epilepsy syndrome, perhaps through genetic testing. And so, but it's recurrent unprovoked seizures, which occur over and over and over. It's just not an isolated seizure or an isolated provoked seizure. So when we look at the characteristics of seizures, they're very episodic. They're often sudden and unexplained. They're very stereotypic, and they can vary in intensity. And there's the prodrome phase, which is the period of time leading up prior to a seizure. The aura, which is an early warning sign right before a bigger seizure may hit. The ictus stage, which is the time frame during the actual seizure. And the postictal stage, which is after the seizure is over and that person is in that recovery stage before they return to their full awareness and activity. So the international, I figured as health professionals, you may be interested in learning a little bit about the change of classifications of seizures. So a couple years ago, the International League Against Epilepsy changed the classification system. And the names are very long and lengthy, but they describe where in the brain the seizure originates from, if there's motor movement involved or speech loss. And so there's 2 big categories, and it's called focal onset seizure. And what this means is that seizure originates from a specific focal area of the brain. Now, the other category is called generalized onset. And what this means is the seizure originates from both sides of the brain. The whole brain is involved. And sometimes the physicians can't identify where in the brain the seizure originates from. And maybe that's because the seizure is originating from deep brain tissue, such as the basal ganglia or the thalamus. And it doesn't, and that data doesn't register on a surface electrode. And so that leads into different epilepsy types and syndromes. There's actually over 40 different syndromes of epilepsy and over 20 different kinds of seizures. And there's no known cure for epilepsy, but it's really important for the treating physicians to identify or to figure out with the data on what kind of seizures an individual may be having. Because, for example, medication, there's some medication that's approved for managing focal seizures. There's other medication that's only approved for managing generalized seizures. And some individuals, they have more than one kind of seizure. There's also comorbidities that may come along with people with epilepsy. And when we look at the statistics, the number one comorbidity with epilepsy is actually depression. Well, it makes sense, because if many people are so fearful when and if a seizures will occur, they get depressed, you know, having their coworkers, their colleagues, their peers, their friends witnessing these seizures. And anything abnormal neurologically in the brain is going to potentially put the person at higher risk for having seizures. So when we look at the data, around 35% of people on the autism spectrum disorder will also have an epilepsy diagnosis. And it's a similar statistic for people with an intellectual disability. 35% of that population will also have an epilepsy diagnosis. And if somebody, for example, has cerebral palsy and an intellectual disability, over 50% of that patient population will have an epilepsy diagnosis. And so there are several comorbidities that may potentially go along with that diagnosis in some individuals. And so you can see the classification system and how it's broke down. There's different levels of consciousness for different kinds of seizures as well. There are some seizures where people lose complete consciousness. There's other kinds where people have impaired consciousness. And yet there's other kinds of epileptic seizures where they don't lose any consciousness. They retain full awareness. So when a physician looks at diagnosing seizures in epilepsy, one of the things that they look at is it truly a seizure? Is it epilepsy? Is there a cause that can be identified through testing? Are there comorbidities present? And it's really important that when people have questionable episodes, symptoms, episodes, or spells, that they write it down when they occur, what the symptoms look like. If caregivers or bystanders can video record that on their smartphone, that is very helpful for the patient and family to show the treating physician. And keeping track on a seizure diary. I know we have a free digital seizure diary called My Seizure Tracker, or My Epilepsy Diary, which can be downloaded on devices and smartphones, where people can keep track the frequency of their seizures. And it even has a component in it for keeping track of their medication, for helping with medication compliance. And so the type of specialists that general physicians refer people to for seizure workup is called a neurologist. And so they'll do a basic physical, they'll do a neurological exam, they'll gather medical history. Oftentimes, many neurology clinics will do imaging with an MRI or CT scan. They'll do a 1 to 2 hour video EEG where they put the electrodes on the head and they monitor the brain waves. And more neurologists are able to get insurance to cover the coverage of epilepsy genetic testing. And many times they start off with the basic epilepsy panel. And depending on the type of symptoms and what's going on with that individual, they may go all the way up to whole exome sequencing or whole genome sequencing. And so basic diagnostic workup with the EEG, CT scan, the MRI scan, all these different data sets are very helpful for that treating neurologist to help determine if it's epilepsy or a seizure or a seizure or some other medical condition. And this is a picture of an example of an EEG reading. The even numbers on this reading actually correlates to the right side of the brain, the odd numbers to the left side of the brain, and then the letters correlate to the portion of the brain where they put the electrodes on. For example, F means frontal lobe, and P is parietal lobe, and T is temporal lobe. And if people don't have these questionable symptoms that frequent, then it may take a few months, or it may take a longer period of time before that physician has enough data to help determine an epilepsy diagnosis or not. Now, there's no cure for epilepsy, as I had mentioned, and the frontline treatment is medication. And if somebody has failed 2 or 3 seizure medications, many times that local neurology clinic is referring them on to a certified level 4 epilepsy center. And at an epilepsy center, there are neurologists who are board certified in epilepsy called epileptologists, and they specialize in treating patients with epilepsy. And at an epilepsy center, they can do advanced imaging, neuropsychological testing. They have extra other types of testing that can be done inpatient, outpatient on an advanced epilepsy monitoring unit to help determine a diagnosis if it's questionable, or to help with other potential treatment options if the medications haven't worked. At an epilepsy center, they're capable and set up to do epilepsy brain surgery, to do neurostimulation devices. There are now other FDA-approved options for managing epileptic seizures, not only the vagus nerve stimulator known as the VNS, but also the RNS, the neuroresponsive stimulator, and deep brain stimulation is now FDA approved for treating epileptic seizures. And also there's a lot of research-based dietary therapies that can help manage epileptic seizures, some of which requires inpatient hospitalization, working with a dedicated dietitian, a nurse practitioner, and an epileptologist. And some of these dietary regimens include the rigorous ketogenic diet, the modified Atkins diet, and even the low glycemic diet for management of seizures. There can also be imitators of epilepsy, and these are other medical challenges that may look like seizures, but they're not. And they come with a lot of different names. There's a psychogenic non-epileptic seizures, and the acronym is PNES. It's actually a conversion disorder, a sotiform disorder. A lot of neurologists don't like to call them non-epileptic seizures. They call them non-epileptic events because the name itself is so confusing, because people hear the word seizure and they automatically think epilepsy. These are events or episodes that clinically look like epileptic seizure, but they're not. And so what the physicians, one of the data that they really like looking at is if these questionable episodes, symptoms, or spells, if they happen to capture that brainwave data when they're hooked up to a video EEG, many times they can tell by looking at that epileptical brainwave reading if it's an epileptic seizure, or say if it's a normal brainwave reading, it could be something else going on. It could be a non-epileptic event. And the reason why it's really, really important for that treating physician to identify what kind it is, if it's epileptic or non-epileptic, is because the treatment options are incredibly different. And so some of these imitators are listed: fainting, migraines, heart rhythm, ADHD, sleep disorder, TIA, mental health, movement disorders. And when we look at the data from the epilepsy monitoring units across the country, about 1 in 5 people with uncontrolled seizures are found to actually have another diagnosis. And so having that data is critically important. And so when the people have epileptic seizures, it's really only the tip of the iceberg, even if the seizures are managed with treatment or medication. And that's because the seizures still could have an impact on quality of life, academic underachievement, mood disorders, depression, anxiety, ADHD, behavior challenges, social isolation. We find a lot of children that are having visible seizures in front of their peers at schools, that they are fearful for returning back to class, for not knowing if students will make fun of them or imitate their seizures. Autism, these comorbidities, injury, accidents. There's just so many different things. Many students with epilepsy meet the eligibility criteria for a 504 plan for accommodations for a lot of these different things to help them access their academics. If they have severe academic deficits, then they may be potentially eligible for an IEP plan, an individualized education plan, and there the accommodations would also be listed on page F of that plan. But epilepsy is certainly a spectrum. There's many people that get an epilepsy diagnosis, they see a neurologist, they go on a medication for their seizure type, and their medication is managed, and they go back to leading the quality of life they were leading prior to the diagnosis. These are general education students, they're student athletes, they're adults that are employed, and they're having a very successful life. On the other end of the spectrum, another individual may have an epilepsy diagnosis, which could be very disabling. The seizures are uncontrolled with treatment options. They're having frequent uncontrolled seizures, or they could be on a lot of seizure medications in hoping to manage the seizures, but the potential side effects are compounding each other, and which impacts their ability to drive, to work, and to be part of the community. So seizures can result in a change in movement, behavior, sensation, speech, and awareness. And what a seizure looks like depends on the area of the brain involved. And that's why it's very important for bystanders when they witness somebody having a seizure is to jot down, for example, was it just one arm jerking and shaking, or was it both arms? Because that could potentially tell the neurologist if it's just one side of the brain involved, a focal seizure, or both sides of the brain involved for generalized seizure. If somebody has visual distortions during their seizure, then that would tell the physician that that seizure most likely originating in the occipital lobe, in that back area of the brain, because that's the part of the brain that controls that function. So now we're going to get into a little bit of the 4 most common kinds of seizures. Now, most people, when they hear the word epilepsy, they think of convulsions. But most seizures do not involve convulsions. So focal aware means that the seizure starts in a specific focal area of the brain, and the person is fully alert and aware. They are fully conscious during this episode or event. Now, this used to be called, on the old classification system, simple partial seizure. So this terminology is interchanged pretty frequent. Now, what it could look like is it could look like odd rhythmic movements of the face or their limbs. Other individuals, the symptoms present itself with sensory symptoms. For example, that person could be describing a tingling feeling in their leg, only they weren't sitting on the ground with their legs crossed. Or they could be describing noises that don't exist. They could say, do you hear that ringing noise? And there's no ringing noise in that environment. Or they're describing smells that don't exist. We had somebody in our support group several years ago, and I'll never forget it. She said, do you smell that skunk? And there was clearly no skunk smell in that library meeting room. But what she said is when I'm hooked up to the video EEG and I have the skunk smell, my brainwave data shows that it's a focal aware seizure. So that's why, and how she knew that smell is what her seizures are, and she can talk and walk through them. Other people have visual changes where they describe seeing a kaleidoscope of colors or colors of the rainbow for about a minute or two, then their vision comes back. And so other people, the seizure presents itself in psychic symptoms. They have hallucinations, deja vu, a funny feeling of fear or anxiety, which could potentially precipitate in behavior, especially if that person is nonverbal. Only you're looking around in that environment and nothing precipitated that. It's a pretty calm atmosphere. And so these symptoms are very subtle. They may look like other medical conditions. Some children get misdiagnosed with other medical conditions, but it can look like the person's in a mystical experience. It could look like illicit drug use or even psychosomatic illness. But usually this event lasts 1 to 3 minutes and it ends on its own. Other times, this seizure could start and quickly secondarily generalize into a bigger seizure. Now, some people have auras, which are warning signs before a bigger seizure hit. Many auras are actually a focal aware seizure. And so if they get the right diagnosis, there's a lot of medication that can help manage this so the person can get their quality of life back. So with this seizure, people can walk and talk, they're fully conscious. But this next kind, people can walk but not talk, because their consciousness is impaired. And so this one is commonly known as the wandering seizure. If you've ever heard of anybody in a wandering seizure, that's what this one is. So focal impaired awareness. So the seizure originates from a specific focal area of the brain, and they have impaired awareness. Now, on the old classification system, this was called complex partial seizure. So again, these terminology is the same thing. It's just, this is what it's called now in the medical community. So what this one looks like is somebody will start off with a blank dazed stare. They're not aware of their surroundings. They're confused. They're disoriented. They have a lot of repeated purposeless movements. They start picking at things. They start picking at the threads on their shirt. If they're sitting at their desk, they're shuffling with their papers, or they're picking up objects, picking them up, putting them down repeatedly. And you're sitting there looking at them thinking, what's going on with this person? They look like they're with it, but they're not. If they're standing upright, they don't collapse to the ground. They retain mobility. They start walking around, confused, disoriented, with no sense of purpose of direction. And so you're saying, Johnny, get back over here. Only Johnny can't respond because he's in this impaired conscious state. And so many times they can't respond to questions or talk. And if you were to come up to a person when they're in this impaired conscious state, say you were to tap on their shoulder or force them to sit down, they could perceive that as a threat and start fending off, pushing back, and getting aggressive. And they don't know what's going on. So think about this one in our adult population. Say somebody got off work and they're walking home. They're wandering, confused, disoriented. If they're trying to talk, they're having slurred speech. Somebody approaches them. They start fending off and getting aggressive. Unfortunately, what this one may look like, it may look like drug use or alcohol use or aggressive behavior. If you've ever heard of anybody wrongfully arrested in a seizure, many times it's this kind of seizure, because unfortunately, that's what it sometimes looks like. Now, the majority of the time for many people, this seizure will run through its course and end on its own in 1 to 3 minutes. And so this is a very common kind of epileptic seizure. So I'm going to show a couple video clips of a focal impaired seizure on what it may potentially look like. So you can see in that video clip, the gentleman's head was turned to the side. He was staring. He had lip smacking and chewing motions with his mouth. And he had some eye blinking going on. And so it looked like somebody is with him, but he wasn't able to respond to them. So take a look at this next one.
Excuse me, sir, come on up and I'll ring you out. Come on, buddy, we're out of here at 5 on Sundays.
So you can see in that video clip, the gentleman maintained his mobility. He was standing upright. He was swaying back and forth on his feet. He was staring. He had lip smacking movements with his mouth. And he had the repetitive tapping on the soda bottle on his hand. The attendant to the front of the store was calling out to him, but he wasn't able to respond. So now that we've talked about the 2 most common kinds of focal seizures, now we're going to talk about the 2 most common kinds of epileptic generalized seizures. So this one is called absent seizures. It's also pronounced absence. These are commonly known as those quick staring spells. Are they or aren't they? And it gets its name because when somebody stares off with a blank stare, you see the absence of the person. And so with this one, the person will stop what they're doing and they'll stare off. They'll have a brief lapse of awareness, sometimes, but not always, chewing motions with their mouth or rapid blinking motions with their eyes. And many times some people have hundreds of these a day. Now, some physicians say if you were to snap your finger or to tap their arm when they're in the staring episode, if they're truly in a generalized absent seizure, they're not going to be able to respond to that touch or stimuli because both sides of the brain is involved and they do have a complete loss of consciousness. Whereas if somebody's just daydreaming, they're going to snap right out of it. Or after somebody after the absent seizure has ended, you could ask that person what the last thing they saw or heard in their environment. which would be what occurred before their staring occurred. They're not going to remember anything that occurred during that staring episode. And so these are very brief events lasting less than 20 seconds. And it's often confused with people daydreaming. It could look like attention challenges. Some children get a misdiagnosis of attention deficit disorder when actually it's just undiagnosed epileptic seizures. And so, and when the staring episode ends, they go back to doing what they were doing. And many times they have no idea that they even missed a gap of time. So this one, you can kind of think about kind of like a light switch going on and off all day. That person is in and out, in and out. They're missing snippets of instruction and they have no idea that they're even missing gaps of time. And when the physicians record this data, the brainwave data on a video EEG, that's one of the data sets that they really look at to help determine if that staring is an epileptic seizure or not. And they find many of these people have hundreds of these a day, which does impact their ability to learn, to work, and quality of life. And so if they can get the right diagnosis, then they can prescribe the right type of medication or treatment option to help manage this for people for a better quality of life. So here is a very brief video clip of what a potential absence seizure may look like. You can see a little bit of swaying back and forth, some chewing motions with the mouth, some staring and blinking motions with the eyes. So this last one we're going to talk about is a generalized tonic-clonic. Now this one is formerly known as grand mal seizure, which is old medical terminology not really used by the medical community anymore. Tonic means stiff and clonic means jerk. And because both sides of the brain is involved, we see involvement with upper extremity, lower extremity, and bilateral on limbs on both sides of the body. So because the diaphragm contracts at the onset of this event, many times there's a loud, piercing cry. There is a complete loss of consciousness. So if somebody was sitting at their desk or table, they could fall out of their chair and hit that ground hard. Or it could look like a full forward head drop where they smack their head on top of that table. If they're standing upright, they'll often collapse with no warning, but their whole body gets very rigid and stiff, which is the tonic phase, followed by the whole body going into rhythmic jerking, which is the clonic phase. Many times people have very shallow breathing. There's a lot of drool and saliva coming out of the mouth, a lot of gasping for air, a lot of gargling noises in the mouth from that saliva. Some people have cyanosis associated with the seizure, where their skin, nail beds, and lips will turn a very darkish, bluish, purplish color. And some people lose bowel or bladder control. And so some of our adult population that lives by themselves, they have no recollection whatsoever when they have these type of seizures. They say, well, I woke up the next morning and my pants were soiled or my bed was wet. And normally that doesn't happen. Or perhaps their jaw was sore. And it's very important for bystanders to time a seizure, especially this one, because this seizure can be so intense. Many people report this lasting 5 to 10 minutes because it seemed like it lasted that long and it was never going to end. But for most people, the majority of the time, the seizure will run its course and end on its own in 1 to 3 minutes. And so after the seizure ends, the recovery time is different for everybody, but for many people, it just takes everything out of them. They're very confused. They may have a headache. Their muscles are tired and sore. They may have bitten their tongue. They may be slurring their speech. I know our daughter had all of this and she couldn't even get up off the ground. She tried to push herself off the ground and her limbs would just collapse. So we would have to do post-seizure transport in a wheelchair or in a wagon or something to get her back to the house or to the vehicle if we were out in the community. So here's a very brief video clip of part of a generalized tonic-clonic seizure and what that may potentially look like. So you can see the body is very rigid, the jerking and shaking movements, the saliva coming out of the mouth, the gasping for air, the staring. Very intense it could be. So now that we've covered how to recognize the 4 most common kinds of seizures, we're going to go over just basic seizure first aid, because you never know when you may see somebody out in the community or in your public health offices of somebody in a seizure. And we talked about earlier how 1 out of every 26 people will have an epilepsy diagnosis, but 1 in every 10 people will have a seizure in their lifetime. 1 in 10. So it is likely that you will see somebody in a seizure in your lifetime. So the Epilepsy Foundation streamlined the seizure first aid protocol to make it easier for the general public to remember. And it's called the Stay Safe Side Protocol, and to time the seizure. And the rule of thumb for many medical professionals is 5 minutes. We talked about how many seizures will run through its course and end on its own in 1 to 3 minutes. So if that seizure is still going strong at the 5-minute mark, it's longer than what it typically lasts, and they may need medical intervention to help stop that lengthy seizure. So we have these seizure first aid posters, which can be downloaded from our epilepsy.com first aid website. So if you were to witness somebody in a seizure, it's important that you stay with the person until they're awake and aware. You never want to leave them unattended. You don't want to yell seizure, seizure, and create unnecessary chaos in the environment. It's important to try to stay calm. You want to time the seizure. If it's somebody you don't know out in the community, check to see if they have a medical ID, or if a familiar person is with them, and ask that familiar person of how you can help. You want to keep the person safe. So, for example, if they're in that focal impaired seizure where they're wandering around, you would want to gently guide them away from hazards and guide them to safety. So you would want to gently guide them away from that brick wall, away from the traffic out on the street, or away from that stairwell so they don't fall down the stairs. If somebody collapsed to a ground in a tonic-clonic seizure, for example, you want to keep them safe by moving the tables, the objects, the chairs out of their way. You want those limbs to jerk and shake freely so no potential fractures or harm comes to that person. Now, you want to turn the person on their side if they are not awake and aware. And the reason why the medical professionals don't recommend leaving the person on their back during a seizure is because that tongue could block that airway, and all that saliva and drool could go back in their throat, and they're at potential risk for aspirating on that fluid. So medical professionals recommend turning the person to their side. It allows that tongue to hang out of the mouth. It allows the saliva to drain out of the side of the mouth. You want to put something small and soft under a head. You may not always have a pillow nearby, but grab a coat, grab a bag, grab a blanket, or take off your sweatshirt or hoodie or coat to use to cushion the head from hitting that hard surface or concrete. You want to loosen the tight clothes around the neckline, the zipper on that winter coat, or the buttons and snaps on that long sleeve shirt or sweatshirt, or the tie if they happen to be at a formal event. You want to also remove the glasses. You never want to restrain somebody in a seizure. You don't want to hold their limbs down when they're jerking and shaking. It's not going to make the seizure stop. And you don't want to restrain somebody when they're in that wandering seizure either. Never, ever put an object in somebody's mouth during a seizure. This is the big teaching that has changed over the years. They used to teach this back in the day, and that's because they thought people would swallow their tongues. But the medical professionals say the tongue is a very strong organ in the mouth, and it's physically impossible to swallow. If you were to put a spoon or object in somebody's mouth during a seizure, they could chip their tooth, they could break their jaw, they could break off the broken piece, and a lot of potential harm could come to that individual. It is a best practice to have for people with a seizure disorder or epilepsy to have a seizure action plan. And it's very important because what is a medical emergency varies from person to person. So this is usually put together with that patient or their parent and guardian with that treating healthcare physician. And the physician will write down the types of seizures they have, how long they normally last, how frequent they occur, what they look like, if there's any rescue medications prescribed, PRN, when seizures require additional help. And it's a great idea to have this updated yearly. And in People give this to their schools so they know what the plan is, the seizure action plan. Children, parents of children give it to their daycare providers. If somebody's on an HCBS waiver, they give it to their respite and SEL providers or the babysitters in the home, or even to their adult caregivers for the elderly. So situations that are definite medical emergencies. If that seizure lasts longer than 5 minutes, we talked about it's longer than what it would typically last, and it may need intervention to help stop a lengthy seizure. Some days with seizures are just really bad, and people have clusters of seizures. This is where they have seizure after seizure, and they're not fully recovered before the next one hits. If somebody has difficulty breathing, anytime a seizure occurs in water, there needs to be a medical evaluation done. Even if you didn't see them go under, they could have taken in water, gotten in their lungs, and aspirate on that fluid. And that's something we don't want to find out about later. If the person took a hard hit, they could have suffered a hard fracture to a limb, or if they took a hard hit to the head, they could have suffered a concussion. Or if the person is pregnant or sick, a medical evaluation needs to be done. Or if the person does not return to their usual state of consciousness after the recovery period after that seizure. Or if it's a first-time seizure or no known history is known. Now, as we wrap up here, before we get to our question and answer period and discussion for the remainder of the hour, I wanted to show a seizure first aid demonstration.
Guys, give us some room. He's having a seizure.
Give me some towels.
Okay. Stay calm. It's going to be fine. Help me get him on his side. All right, listen up, fellas. Before we practice, I want to go over a couple of things. First, I'd like to welcome back Michael. Huh? Good to have you back. We all know Michael has epilepsy, and he shared his seizure with us in the game. He has something he wants to say.
Yeah, thank you all for supporting me, and thanks to Coach for knowing what to do. I'm sorry if my seizure scared you guys. It could be scary for me too, but what's even more scary is if people didn't know what to do.
So today, we are going to learn seizure first aid thanks to the Epilepsy Foundation. We're teammates, right? We take care of one another, we count on one another, and when anyone with epilepsy has a seizure in front of you, they're your teammate, and they're counting on you. So, first, stay with him. Okay, stay calm and keep others around you calm and out of the way. Protect him, keep him safe. It's also important to remember that the person having the seizure should be lying down and that there is nothing harmful in their way. Turn them on their side and support their head so that they're not banging it and so they don't choke. Never put anything in their mouths and do not hold them down. Time the seizure till the very end. Okay. Knowing how long the seizure lasts is important information for the doctors to know. If the seizure lasts more than 5 minutes, call 911. When you see somebody having a seizure, you're going to feel a little powerless. But if you protect them and if you stick with them by their side, you're doing the right thing. Okay? All right, let's practice this.
Bulldogs on 3. 1, 2, 3. Bulldogs! Let's go. Yeah.
So just a great example of seizure first aid demonstration. So we have a lot of other video clips on different areas of seizures and epilepsy on the Epilepsy Foundation YouTube channel. You can find more information about seizures and epilepsy at epilepsy.com. It's the #1 resource in the world, and it's authored by medical professionals. So it's a credible, reputable website. You can search for specific kinds of seizures, treatment options, anything and everything you want to know. Just know that's a reliable place to get information. We do have a seizure and epilepsy 24/7 helpline where people can call in and speak with somebody live for general information as well. That's 1-800-332-1000. And then we want to continue to be a resource here across the state of Iowa at epilepsyiowa.org. And then my phone number and our email, iowa@efa.org, is listed as well. A lot of people have challenges with transportation, housing, employment, disability denials. The list goes on and on. Many people with epilepsy fall through the gaps of the system for help. And so we are pretty serious of trying to help navigate resources and connecting people with hopefully meaningful resources so they can live the best life possible with their epilepsy. So with that, Brett, I don't know if we have any questions, or would love to have a discussion and hear from people and maybe what they've seen for seizures or questions that they may have. Sorry.
All right. Well, thank you for all that fantastic information. If there's any questions, I see one in the chat now. What are your suggestions for reducing social stigma in schools? A great question, John.
So that's a great question on reducing social stigma in schools. The best thing we can do is educate students. We do have our Take Charge education epilepsy programs, and we have programs designed for elementary students, middle school students, and high school students. And that really helps a lot. And school nurses can give the Take Charge programs as well. And we have our 1-hour seizure training for school personnel program to educate school staff. And then we have a 3-hour education program specifically for school nurses.
Do you have any other questions for Roxanne? You put it in the chat, or you can go on.
Next question is, can you talk about seizure safe schools legislation? Absolutely. So it's been a priority for the Epilepsy Foundation to improve student safety in schools for students that have seizures. There are 12 states that have passed legislation, and we are working on this initiative in the state of Iowa. So we have a bill called, it's House File 795, or Seizure Safe Schools Bill, and it passed last legislative session with a strong bipartisan support. And we're hoping to get it through in the Senate. But the components of that bill have to do with educating school staff across the state on how to recognize and respond to a seizure. If a student has a seizure disorder diagnosis and medication needs to be administered during the school day, we just want to make sure that there's somebody in that school building trained on how to administer and use that medication, because there's not enough school nurses in our schools, and many nurses are employed part-time, or they cover multiple buildings, multiple towns. And then the last component of the legislation is making sure that every student with seizures has a seizure action plan on file at this school. So the school staff know exactly what the protocol is for that specific student. The next question: is there an effort to get seizure first aid incorporated into the more general first aid courses that many people take for the Red Cross, for example? Yes, that is very much needed. And we do have people with the national office that have been working with the Red Cross and the American Heart Association. I just re-upped my CPR a few weeks ago through the American Heart Association, and there was still very limited information on seizures. And they're still teaching to turn people on their side in the recovery stage and not during a seizure. So there's still not a lot of work. There still is a lot of work that needs to be done in that area. I'm just wondering too, what else can we do to help support public health for you all on the call across the state for those that you encounter with seizures in your communities?
So, Roxanne, this is Lena with IPHA. I imagine that similar to other conditions, medical conditions and such, there's an equity issue and that we see with people that have seizures. And I'm wondering, I don't know if this is a response to your question, but overall, I think there's likely an importance to recognize seizures, across race, gender, age, and all that, to make sure that we aren't inappropriately diagnosing or even criminalizing seizure. So I don't know if you have any suggestions or way what the Epilepsy Foundation or others are doing in terms of recognizing that and the equity and the inequities that likely exist.
Yeah, that is something that the National Epilepsy Foundation is working on across the country. I know one of the things that they've done is our seizure first aid posters is they have developed that in different languages. And the Epilepsy Foundation just was awarded another 5-year grant from the Center for Disease Control, which starts this year for 5 years. And one component of that is equity. So Lena, look for more to come on that issue across the country and even in Iowa, especially when you look at the Hispanic population in our state. For more resources and assistance with that. Now, for example, with the Hispanic population, we do have a 24/7 helpline available with a Spanish-speaking person, and we've developed a lot of our pamphlets, brochures, and resources in Spanish as well.
All right, do we have any other questions or comments for Roxanne?
Just appreciate the opportunity to educate today. The Iowa Public Health Association has been a wonderful partner with us over the years and was on the recent legislative forum, and that's always a great way to collaborate with many people across the state as well on important health issues. So don't hesitate to reach out at any time to us to help with resources and support for those that you serve in your counties and in areas.
Thank you. As Jeremy says, not a lot of people, not everyone knows some of this critical information about seizures. So this is really great information to have. I appreciate that, Roxanne. Thank you for sharing your expertise today. If anybody else has any last minute questions, feel free to jump in and interrupt me. Otherwise, I'll lead us out and can head into our 1 o'clock. Thank you, Roxanne, for sharing your expertise. Thanks to everybody who came today and shared their lunchtime with us. We hope you can join us again next month. I think it'll be Thursday the 20th. We'll be joined by Ann Saba from the University of Iowa Prevention Research Center. The Education Committee is always looking for potential topics for future lunch and learns. We welcome your ideas to help showcase yours or other people's work, and we encourage anyone with an interest to join the committee. Just a reminder, as a nonprofit organization, IPHA relies on membership dues and sustaining donors to help support our mission. If you're not already a member, please consider joining IPHA. If you have any students here, you can check with your department chair. Some programs have funds to help support your membership. If you are a member, we thank you. We appreciate any donation that fits within your budget. You can join and give at iowapha.org. You can find the recording of this Lunch and Learn and any previous one on the Iowa Public Health Association YouTube channel, where you'll also find any other webinars that you may have missed or want to revisit. Thank you again, Roxanne. Thank you all for coming. We hope to see you next month.